With a focus on advancing emergency care, Zoll delivers innovative, user-friendly technology designed for where and how you work, and for the patients who rely on the care you provide. Zoll is committed to helping you save more lives.
Okay, so now let's invite Prof. Tham up on stage again to give us some proper insights on medical education, shall we? Prof. Tham, please.
Thank you. I'm definitely not as funny as these four guys, that I can assure you. I've chosen the title Clinician Educator to be or not to be, and this talk, unlike, say, the last year's talk, is probably a little bit more lighthearted. But still, I take my hats off to these four gentlemen. And I must say that, coming from the older generation, I'm glad your generation is able to look at things a little bit more, with a little bit more humor. The emergency medicine faculty will benefit, but I think let's just confine it to your generations. I need to provide some definitions and assumptions because education is very contextualized, especially in terms of how education is funded and the value that medical education or clinical education is placed in a society, in the healthcare system. I'm going to use three personas, typically representing the kind of emergency medicine doctors and nurses, especially in our healthcare system at the moment. And then this question, who is asking this question, is an important perspective to consider. And when this question is asked, then who is providing the answer before I summarize? So this talk is meant for a Singaporean audience, and we have made tremendous changes in the education for doctors as well as for nurses in the last 5 to 6 years. The doctors, especially in the switch to the residency system, was quite a painful move, and the pain is still lingering somewhat. And nurses are facing quite a big change coming up in front of them because at this moment, the nursing leadership across the whole nation are making proposals at MOH that will fundamentally change quite a number of things for the nursing education part. The other assumption that I need to share is that in my cluster in Tan Tock Seng, no doctor gives up his or her clinical work to become a full-time educator or researcher or administrator. No go. Even my chairman medical board tries, and he's an anesthetist and neurointensivist. He still sets aside time within his super packed work week or work month to get back into theatre to practice as an anesthetist. So that's the background that I come from. And I'm sure for most of the doctors, that's what we understand it to be. But we need to say it up front because for nursing, a lot of the nursing groups in the various hospitals, they have taken a different stand. For them, if you become a nurse educator, you walk away from clinical work. Okay. The two systems have got their own advantages and disadvantages. So today's talk is not to debate that, but the assumption, the understanding is for doctors, we don't walk away from clinical work. No matter how hard, we keep a part of the practice. MOH caused a bit of confusion for me, at least, when they came up with this definition, the words in blue, and they used the term clinical educator. But if you look at all the words, the two sentences, the two lines in bold, the clinical educator is somebody who provides individualized guidance, supervision, support, assessment for trainees' learning experience. The summary of it is just one word. The clinical educator teaches. That's what a teacher does. It doesn't matter whether you name this person clinical educator, which is MOH preferred term, or clinical teacher, tutor, preceptor, supervisor, mentor, instructor. It's not relevant. The core activity is that of a teacher. And the relationship at that point in time is a teacher to student relationship. There is not much of a teacher to system relationship in this definition. Tan Tock Seng made the move 3 years ago that every doctor, 10% of the doctor's work is set aside for teaching and related work, because sometimes you do have to attend meetings. So 10% of our time in our annual appraisal is given to teaching. If you refuse to teach, that 10% in your annual appraisal will be 0. Okay? So that's how much we have hardwired into our annual appraisal system. There are advantages and disadvantages. Again, today we are not going to concentrate on that, but that's the background that I do come from. What does it translate into? It means in a typical emergency physician or emergency nurse, if we go down the track, go down a similar system for the nurses, it's about 4 hours a week or 2 days a month dedicated to just teaching and related activities. That's quite a substantial amount of time if you think about it. For today's talk, I've chosen the term clinician educator because the job description of a clinician educator is actually the other things about providing education leadership, administering program of the curriculum, the upstream work, that means like designing a curriculum, quality control in the curriculum, innovating, making sure that it gets updated, exams and assessment related system setting up. Those are what I call upstream activities. Okay. And I have intentionally put the word teach very small because a good clinician educator, especially working in a big, busy hospital, and most of our hospitals are extremely busy, with hundreds of medical students going through and a significant number of junior doctors and residents going through. If you are doing the work of a clinician educator, your personal time to teach becomes the first thing to sacrifice after your clinical time. Because somebody has to go and make decisions about the budget, right? Somebody has to make decisions about, is this the MCQ paper that you want to launch on your unsuspecting residents or not? Okay. Is there room for improvement in the way we teach? Is this timetable meeting the requirement of the curriculum? Are my residents going to pass exams? So that's what a clinician educator is doing. A lot of the time, you're not dealing with the individual relationship with your students or your residents, but really at a system level, making sure that the system supports the clinical teacher properly. So, in Tan Tock Seng, the other understanding that we have is nobody is given the role or the work of a clinician educator if this person is not able to garner funding from outside. So we try as much as possible not to allow any one of my new ACs or my Cs. So all my residents sitting here, open your ears, okay? If you want to become a clinician educator, you need to have funding. In other words, ED work, the money that we earn or the income that we bring in by providing service, we cannot cross-subsidize that money to do education work at the level of a clinician educator. The money that we bring in through rendering service definitely funds the clinical teacher. That means this level of work, that's cross-subsidy from service. But this level of work, we are looking at residency program, the medical school, MOH work that will pay for this work. Why is this important? I will go on to explain a little bit more in my subsequent slides. So having dealt with the assumptions and the definitions, I'm going to introduce 3 personas. What are personas? They are typically role or character crafted by an author. They are either based on a real individual or a composite kind of figure, and they are representative of their generation or the particular group that they come from. So these 3 personas that I'm sharing are real people in my system, and I thought to try and anonymize as much as possible, I'm going to use Ang Mo faces, okay? So the first one is Liz. Liz is one of our very talented senior residents. And Liz tells program director as well as head of department that when I finish my residency, when I finish my exit exam, I want to be an educator. Okay? In Tan Tock Seng, this is heard 4 residents out of 5. And in Tan Tock Seng, the heads of department across of all Tan Tock Seng, our biggest worry is everybody wants to be an educator and teach. Nobody wants to be head of department next generation. Nobody wants to do research. Yeah, see, my residents are nodding away and grinning at me. So, head of department predictably said, yes, you can teach the residents and the students, but no, you cannot be a clinician educator. Why do you think my head of department, or the Tan Tock Seng head of department, gives an answer like this? Funding. Mm-hmm. Anything else? Manpower. What about manpower? Yes. If I have 4 out of 5 residents and NHG has, at steady state by now, we're probably having about 300, 400 something. If 75, 80% of my residents just want to teach, and they are not really interested in research, they are not really interested in become master clinicians, and worse, I cannot raise my next generation of heads of department, Tan Tock Seng will fall apart. Second persona, Jerry. This is a newly promoted consultant. The feedback given by students and residents and junior doctors to him when it comes to his teaching is always very good, glowing. Okay? And he tells the head of the department, I want to do serious education work. But the head department makes the note of this. At a consultant level, he's still getting complaints about communication skills with patients. We have colleagues like this, right? You know, when they are dealing with one group of people, they are like so good. And then they do this 180 degrees turn, and they are like, how can you be talking like that to the nurses or to the patient? But there you are. That's the complexity of organized life. So the head of the department decides not to make a decision and comes to the ACMB education and said, do you think Jerry is suitable for serious education work? So what do you think ACMB education should say? Lesser evil. So shun him to do education work because it's the lesser evil. Okay, I'm going to go on to the third persona. Wilfred. This is a multi-talented, dually accredited specialist in our system and a multiple award-winning educator, one of the, not just NHG, but this nation's A-star ex-program director. Wilfred is funded at 60% of his work to do clinician educator work as a principal lead for one of the undergraduate programs, as a core faculty for residency, and MOH pays part of his FTE for MOH level kind of work as well. In short, this is really one of our superstar clinician educator. Head of department tells Wilfred, I want you to be the next head of department. And this is a big department. Wilfred is very reluctant. So what do you think head of department should do? Force or don't force? Who says, make Wilfred become head of department? Okay, who says, don't do it? Let Wilfred stay as a superstar clinician educator. Okay, so I have more of those who say, don't disturb Wilfred. Okay. So here we are, and I think this is the dilemma that Singapore faces in every hospital. Today's talk is about education. In other hospitals, it could be about research. Okay, yeah, it is really about the departments and the organization's needs versus the individual clinician's aspiration. And aspiration, not in terms of extrinsic motivation where people or things are pushing or circumstances are pushing us to do something. The most powerful things are usually the intrinsic things. Purpose, mastery, and autonomy. What's purpose? Purpose means, in me, I truly believe that teaching and education is intrinsically worthy of my effort, to the point where even if it doesn't pay me that well, I am willing to do it because of its intrinsic worth. That is purpose. What's mastery? Mastery is if I believe in the value of education, in the work of education on its own, then it is worthy of my best efforts. Okay, that's mastery. What's autonomy? Autonomy is this best effort that I'm going to put in needs to be contextualized. That means I'm not going to do this just because MOH wants me to do this. I want to do this because in my practice, in my department, in my organization, this makes sense. So I'm going to use a larger example to illustrate what these three things have in terms of understanding. When Ministry of Health came down, top-down heavy, and said, we're going to change the way we train our specialists from the old system into residency. All of us who are caught in that change, yes, we can see the purpose. It is a better system. That system is worthy of emulation and adoption. So purpose is there. And we can master it. That means, since MOH has said that we will go forward and we have to go forward, now that I've made this decision already, I will put my best. So you see all the three sponsoring institutions really gathering good teams, good programs, shaping up, and best effort, best foot forward. But we lost autonomy in the process. Why? Because American ACGME International, lock, stock, and barrel, including very irrelevant standards, were just imposed upon us. So in that ACGME move, the residency move, the doctors faced a problem of autonomy. We know the purpose and we buy. We believe we can do it, so we put in the effort for mastery. But it is only now that we are able to go up to the Americans and said, we need to contextualize this. And finally, we are on the move to regain that part of autonomy that we lost 5-6 years ago when we made that move. I think we're on a good footing now. We are probably mature enough as a system to take the best from the system to the Americans and then move forward on that. So who's asking the question? If this question of clinician, educator, to be or not to be, is going to be asked by the organization, the point of view of the bosses are going to be very different. And I have been there. Okay? It troubles me tremendously to say no to a resident who says, Dr. Tham, I really want to be like you. I said, no, I'm not a good person to be. Okay. Number one, manpower is going to be a real issue. Okay. If I don't even have enough warm bodies to do the work, okay, I can't worry about the rest. So for certain departments where warm bodies, manpower is enough, the next thing is, it's not just the number of warm bodies, it's the quality of that manpower. So this is where talent is. Recruiting talents, identifying them, okay, distributing. It's not just education that needs talented people. We need to groom the next generation of heads of department, div chair, CMBs. We need to groom researchers as well. So distributing and nurturing the talent into those respective fields or tracks. Managing and ensuring that they stay well and productive once they are in that track. And for those who are not performing well, how to exit without damaging the person and the working relationship. And of course, as my generation grows older, how are we going to step away and hand the baton over to the next generation gracefully? That means the retirement part needs to be thought about. And of course, money to do the above and many other things. So if I am the boss asking this question, that's my point of view. But if I'm the individual clinician, fired by purpose, the need for purpose, for mastery, and for autonomy, what influences me? Role models. It's not curriculum. It is the people that you pick, that you think, when I grow up, I want to be like them. That is going to be really powerful. Secondly, where you work. Department, organizational, environment, and culture. If you work in an environment that is very pro-teaching, and then the boss, the new boss comes around and said, we are not productive enough for a hospital this size for research. Everybody looks at the boss politely, and then waits. And then the boss tries his best to move resources here and there. 6 months later, the amount of resources moved to research is like minuscule. No matter what the boss says next, doesn't cut any ice anymore about research. And of course, personal inclination. Those of my residents who join NHG, the first thing they tell us is, I want to teach. So we said, fine, yeah, you can teach. But, beyond that, let's see how you perform. And it's important to remember that for the clinician individually, there are trades-off. My generation, we can afford to be jack of all trades and master of none because the KPIs on us didn't even exist. Your generation, especially the residents, that's different. If you want to be a jack of all trades and master of none, it's going to be very difficult to survive in the system because now we are not spreading people thin. We want people to develop depth. Depth means expertise. Expertise means concentrating on a certain specialty or certain track. And that's how things have evolved. Okay. There will be sacrifices on family and personal time if you want to become good or an expert in something. And of course, there is financial consideration. Fortunately for the emergency physician, emergency nurses, this is not a big deal. But if you look at the people who do intervention, the cardiologists, the surgeons, the procedurists, if they spend time teaching, doing education work, that's time away from clinical work. The income impact is there, not just for them as individual, but as a department and a hospital as well. So for certain specialty, financial consideration is a major thing to think about. Having asked the question, who is providing answers? So for the bosses who are inside here with us, talent deserves your time. This is a generation who has grown up with the individual touch. If you value them, please spend time to get to know them individually. Next. The next generation of emergency physicians and nurses, don't move with hard moves. You nudge. And the best nudge is choose your role models and position these role models next to them. If you want this particular resident to grow up as a researcher, then you choose the supervisor, role model, a researcher, and make the teachers and educators stay away. Trust me, this is very good, okay? And Next point, you need to manage your environment and culture, because what is not said but experienced by your new talent, your emerging talent, is much more powerful than what is said and not experienced. This is the whole concept behind a hidden curriculum. No matter what the boss says, if it doesn't gel with what the resident or the new nurse experiences, the experience will stick and not the boss's word. Then, of course, communicate early, regularly about the department and organization, vision, strategy, and opportunities for the next generation as well. If this is from the individual clinician's point of view, first and foremost, I urge that we need to stay credible, because if you are not credible and not authentic as a clinician, you will lose the touch, the ground feel very soon, and going forward will be difficult already. Secondly, please be open and receptive to alternatives and other opportunities. Within education itself, within the larger organization, and certainly at the national level, we have online at least 3, if not 4 new hospitals coming up. There are opportunities there. Communicate early and regularly with supervisor, role model, program director, and head department. That means if you are really hung up and you want to be a clinician educator, say it early so that we can put in place the things to facilitate your passage or to gently nudge you to another direction, okay? Remember, this is team together. You are part of a team. And if your department and organization is not thriving, the individual clinician may not even survive, let alone thrive. You're not in private practice. You're part of a restructured hospital. There are departments. Your department does well, you have a much higher chances of doing well. The second thing is, truly, if you are multi-talented, then you will blossom in any portfolio so long as you put your mind, your heart, your hands to it, and you're given a good facilitator, a good mentor. I'm going to summarize with the 3 personas. So the outcome for Liz, the senior resident. The head of department decides to send a role model to influence Liz and communicate the alternatives and other opportunities beyond just the very stereotyped clinician educator role. And this strategy will work because at the senior resident level, they are still quite malleable. That means they are not very fixated yet. The second person, Jerry, okay, after discussing with the head department, we felt that it is important for Jerry to work on the communication skills with patients. That goes down back to the credibility as a clinician. If this clinician has difficulty with one of the fundamental abilities to communicate well with patients, I'm not sure Jerry is going to make a very good teacher in the long run as a role model for students and residents. And Wilfred, after a lot of persuasion involving division chair and chairman medical board as well, Wilfred finally said yes to headship, but along the way, we made sure that we identified second ICs to help take some of the other portfolios away from the hardcore headship work that Wilfred has to do in order that Wilfred can keep 1 or 2 of the really key education portfolio. So we managed to work a win-win situation for Wilfred. With that, thank you very much.
I know some of you might have questions for Prof. Tham, but we'll reserve the Q&A session for right at the end, okay?